biomarkers such as CHAPE in Adam 12 here or BNPR1 that really did not change. And similarly to beta-catenin, when you look at week 0 and week 4, K15 or CIMIC, and you could actually see here the clinical outcome and trajectory of healing, it's not in place. So this patient clearly is a non-healer. Now, how can we really say that up front is really one thing that we are trying to figure out. And then again, this is a profile of a healing ulcer, as I showed before, and again, there is a complete decrease of Adam 12 and decrease of BNPR1, and there is a decrease of beta-catenin and restoration of K15 and loss of CIMIC, and look at the trajectory of the wound is healing. Right, so again, doing this approach with the clinical outcome hand in hand really gives us tremendous potential to search for really appropriate biomarker. But so far, we're narrowing down the list, and we are in a clinical study where we are testing this prospectively and trying really to narrow down both the list of the genes and the cellular biomarkers that can really guide us through this process, clinical process. So, but I really hope that we will have a gene chip for wounds relatively soon, and hopefully sooner than later. But clearly, our goals are, as I said, which one would heal up front, and where is the debridement margin, and again, we are now using all the possible approaches. And I want to point out one other thing, and this is again the wonderful world of gadgets and all development in computational medicine, if you want, that is happening right now. And I want to point out my collaboration, a long-standing collaboration with Dr. Graham, who has developed a wound electronic medical record. So he has a research tool that has that follows 132 clinical variables for each patient. So imagine how wonderful that could be, right? So he's following from the wound size that is measured all the time to every single aspect that is important, any clinical parameter, all presence of infection, all the treatments, everything that might be important for the wound healing. So what we are now trying to do is build a platform that can now sort of link this clinical data. This is data that can be exported in the Excel, and it's a searchable Excel table. So imagine if we could now feed all these biomarkers and all these things that we are doing for the tissue for this patient and really connect it with this clinical outcomes and variables that he's doing, and really being able to pin out a subset of patients and really do a more personalized approach rather than this general sort of groups of different non-healing wounds. And of course, one of the apps for that would be wonderful, and that's sort of our goal would be that one day every clinician who treats wounds will have its app, and that app will send a little message and say, okay, there are biomarkers, there is a non-healing outcome coming, please do what your protocol tells you to do. And I think this is the reality, and I think we are there, and that's a really great place to be. Now I will just a few more minutes talk about a couple of approaches of the other side. So, and that is really the reverse, how to reverse the fortune of these cells. And obviously, we can circumvent the missing signals by different ways. One is obviously using those different approaches, and then I have to say gene delivery methods today are really quite well developed, and skin is ideal subject for that simply because it's topical, and especially wounds, because for wounds you don't have to have a long term. You actually have to have gene delivery that will stimulate the healing but doesn't have to stay there 3 years. It can really be temporal. And I think that is really a wonderful place to start really applying gene therapy. Obviously, we could apply a lot of different cells to wounds, and that is different therapies that are both FDA approved and new ones that are being developed. So these are, they could be obviously